Hello, and welcome to the Clinical Care Options and Practicing Clinicians Exchange Infectious Disease podcast. I'm your host, Kim Neely. In the last of this 3-episode series, we hear from an emergency department physician, Dr. Lilly C from Jackson Memorial Hospital in Miami, Florida. She will discuss the best practices in managing uncomplicated UTIs in the emergency department. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started to hear Dr. Lee's insights on optimizing the management of uncomplicated UTIs when care gets complicated.
Now, I just want to bring up some of the clinical considerations, especially if the patient presents to the emergency department. So, ED is open and available around the clock. It's estimated that 1 in 2 medical encounter now occurs in the ED. And in 2019, 151 million ED visits per CDC. And during the pandemic, we did see a slight decrease, about 14%, but has since rebounded and people coming in older and sicker. And urinary tract infection is the 7th most common chief complaint presenting to the emergency department. Over 2 million of these visits were complicated UTI between 2016 and 2018. About 2/3 of these were admitted. Less than 10% met criteria for severe sepsis or septic shock, but at a burden of $3.2 billion to our nation in 2018. So what are some of the challenges of patient presenting to the emergency department? You saw the huge volumes, so there's high patient turnover. There is decreased continuity of care. We oftentimes don't have much information about the patient, and then there's also limited opportunities for follow-up. And importantly also, treatment decisions often are made in the absence of microbiologic data. And then more and more, we're seeing a significant population who come in because of healthcare disparities, be it housing insecurity or poorly controlled comorbidities, also associated with psychiatric comorbidities and substance abuse disorder. They're coming in later and because of barriers of timely care, so the more advanced disease, and oftentimes non-adherence as well. So when, patient with urinary tract infection, when are you considering outpatient versus emergency department care? Obviously, for all these patients, we consider the extent of the illness, right? The severity and extent. But we'll talk about some of the complicating factors that could help us assess concern for progression of disease, concern for multi-drug resistant organisms. There are access to care, how uncomfortable, what a burden it is to the patient. If it's a nighttime or during the weekend, these patients may come to the emergency department just because they're so uncomfortable. And as I also mentioned before, unfortunately, there's a significant population that has so much social determinant of health and other issues that they basically use the emergency department or urgent care center really for all of their care. So in 2018, Jorgensen did a study looking at patient population who are at risk for return to the ED after an index visit to the emergency department for urinary tract infection treatment. And it showed that age is a significant factor, greater 65 years old, pregnancy, nursing home patients, patient with cognitive impairment, patient with psychiatric comorbidities, patient with obstructive uropathy, patient with recent healthcare exposure, temperature greater than or equal to 38 centigrade, tachycardia, heart rate greater than 100 beats per minute, and bacteremia. So similar to the population that we're talking about people at risk, right? And what are the specific patient factors we should consider? Age is one, but again, we heard about spinal cord injury. These patients have impaired sensory functions, and therefore they may not present as usual. They may just show increased spasticity, or they may show autonomic dysreflexia as indication of a urinary tract infection. And unfortunately, because of the difficulty in ascertaining in any sort of symptoms, this is also the population that gets treated for asymptomatic bacteria inappropriately, right? Uncontrolled diabetes. We also heard about any sort of anatomic abnormalities and recent or upcoming instrumentation and prior treatment failure. Immune status. Patient with immunosuppressive conditions like on chemotherapy, transplant patients, or patients with AIDS, or patients with sickle cell disease, chronic, which has functional asplenia that's predisposed them to significant illness. And we also mentioned prior renal transplant. That population, unfortunately, has a shortened ureter secondary to their transplant status, and their ureter does not have a reflex mechanism. It put them at higher risk from going from a UTI to pyelonephritis, and with progression potentially to septic shock, very concerning. And pregnancy status. The smooth muscle relaxation status results in urethral dilatation, and again, can increase the possibility of going from a urinary infection to a pyelonephritis. And in this population, it's been associated with low birth weight, preeclampsia, as well as preterm labor. So what do we do when we assess for, a patient presenting with complaints of, with signs and symptoms of urinary tract infection? The key thing here for us in the emergency department is to assess whether some person is very ill or not too ill, whether they're going to be discharged or going to be admitted. And also look at the clinical picture, their risk for progression of disease, and all their other risk factors. And obviously the concern for progression of disease would be progressing to pyelonephritis, to bacteremia, or to severe septic shock. And additionally, if we were to discharge the patient, are there barriers to receiving and completing care? And if they're admitted, what level of care do they require? And I would submit to you that most of the time, uncomplicated acute pyelonephritis is a clinical diagnosis. But there's certainly times when we're concerned for progression of disease that we may need additional imaging. And the two modalities that we would use in the emergency department with CAT scans and ultrasound. And this is what the American College of Radiology recommends for acute pyelonephritis. They do recommend the CT as being most sensitive and specific. And this is really when you really need better definition of any sort of anatomic abnormalities or calculi, gas-forming infections, hemorrhage, obstruction, or perinephric abscesses. It is more expensive and it does has radiation exposure. You could use the ultrasound. It is less expensive and you avoid radiation, but you receive much less information. And we reserve this primarily to the pediatric population as well as pregnancy, a patient with pregnant status. We also use it to follow up on patients who initially have had a CAT scan and now return for worsening symptoms. We could sort of check to see if there's been any change or resolution of hydronephrosis, for instance. So going back to the challenges in the emergency department, right? We really often lack any microbiologic data. And we also have significant problems with continuity of care. And I would submit to you that antimicrobial stewardship in the emergency department can help with optimizing or improving those particular constraints. And ED is often underrepresented as a focus antimicrobial stewardship efforts. It is not an easy proposition. It does require a multidisciplinary approach between the emergency department, infectious disease, pathology, the lab, pharmacy, and nursing. So it has to be collaborative. It has to be protocol driven. There has to be understanding of the responsibilities of each group. And it has to be patient-centered, obviously, because it depends on the patient's comorbidities and their access issues. And it has to be supported by hospital administration. And with part of this program, what you will end up with is an ED-specific antibiogram that will improve empirical antibiotic selections for our providers. And also integral to all of this, you do have a robust culture follow-up program in order to ensure that you provide appropriate patient care to you. So we've heard often now when not to order urine culture. And this is very important because it can result in over-testing and over-treatment if it's not appropriate. So for emergency department, we often now order a urine analysis that's reflex to a culture. It's an order that is consistent and is used by everyone. But most importantly is that what's behind the criteria that you use for urine analysis that would then reflex to a culture to ensure appropriate testing. So as you can see here, it's important to select the criteria in such a way that would yield the largest positive predictive value. And those would reduce, hopefully, unnecessary antibiotic usage. So this is a key component to limit over-testing, over-treatment. Another significant part of that stewardship program is often pharmacist-led follow-up program. And in this case, the pharmacists review all the culture reports every day. They then follow up in the cases and looked at what is discharged and compare that to the culture results. They then call the patient back to continue or intervene with their treatment plan. And if it's appropriate, escalate to the physician to sort of further get further recommendations. And also, most importantly, this is documented in the EMR. Also, the information is sent back to the primary care provider, the consultants that are involved with the care of the patient, as well as the admitting team that might have discharged the patient. So specifically, the pharmacists look at the urine culture and see if it's resistant to the prescribed agent. They also verify again that if there's allergies to the prescribed agent, they would change the medication. Look for renal dose adjustment, look for any sort of drug-drug or drug-disease state interaction, and then look for duration to make sure there's adequate duration for the diagnosis that the patient was discharged with. When do they escalate to the physician? When we do not prescribe antibiotics and patient comes back with a positive urine culture, a discussion is had so that we can review to ensure that perhaps the patient does not require antibiotics. Perhaps this is really an asymptomatic bacteriuria. Also, when patients get the follow-up call, they may report new or worsening symptoms. This is the opportunity for us to reevaluate the patient, either through the telephone or advise them to come back. And then, unfortunately, oftentimes we also see cultures that are now resistant to oral agents, and they may have to be brought back for IV antibiotics. We have occasionally tried the fosfomycin pill option in our institution, but again, that requires for them to come back for us to do further testing on the urine and then prescribe that. But if that's an option, it would actually eliminate the need for them to stay for long-term IV antibiotics. So in summary, in this, the pharmacist-led UTI treatment protocol and education increases optimal antibiotic prescribing, and it decreases the prevalence of antibiotic failure at 72 hours and 30 days. In summary, so some of the strategies we developed to overcome barriers in the ED, I think number one, it's antimicrobial stewardship. We've been able to develop the ED-specific antibiogram that is used by all the providers as much as possible. And it requires a multidisciplinary team, and the pharmacist is a key part of this. They do the burden of the follow-up. We provide this education to our providers and residents. And of course, we also give them feedback on the individual cases requires change. And then most importantly, as I mentioned before, communication back to the primary care provider or the consultants that are caring for the patients. Regarding the barriers that I mentioned, recent studies have shown that single dose of IV ceftriaxone is as effective as IV ceftriaxone combined with the discharge antibiotics. So for a specific population, this might really be the treatment of choice. Other needs that we need to be cognizant about is that physicians should really be providing generic prescriptions or at the prescribing prescriptions that are the lowest cost possible, and educating the patients regarding local resource to obtain affordable and accessible therapy. Additionally, in our institution, there are safety net antibiotics for the under-resourced patient. So that if they really do not have any money at all, it can be given to the patient free from the emergency department. But also importantly, we communicate to the plan, to the patient, so that they provide appropriate follow-up contact information, either telephone number or shelter, where we can actually follow up with them regarding the results of their culture. A summary of the strategy for patient who has significant adherence, access, and cost barriers. I think single-dose antibiotic regimen is very appropriate. For patient who requires education, and adherence, education is important so that they can understand their disease state and the reason for treatment and the length of treatment, so they improve compliance. If access is an issue in terms of cost, I think it's very important that we provide the generic medication at the lowest cost possible to the patient, but also to educate them about local resources. And of course, in general, we should, as much as possible, follow the phone call, especially if there's a change in treatment required. It's important to be able to convey that to the patient.
I'd like to thank Dr. Lee for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and to access the full program on Uncomplicated Doesn't Mean Easy, recognizing the burden and preventing treatment failure of uncomplicated UTIs, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.